To all, first of all, I thank the organizing committee to give me the opportunity to present this topic here. Actually, I am going to speak about the decision making and surgical management of upper brachial plexus injury in pediatric as well as the adult patients. So previously, these brachial plexus injuries were faced with pessimism, S palsy. Now the terminology has changed. Like it is now called the birth brachial plexus injury, or previously we used to call it obstetric palsy. So better now it is better to call like birth brachial plexus injury to avoid the putting the blame on the obstetrician. Okay. Now the most important thing in assessment is the clinical examination. And in birth brachial plexus injury, we usually don't rely on the nerve conduction study or the MRI, because these are practically very difficult to do in kids and very difficult to interpret, because it's based upon the radiologist and as well as the neurologist efficiency to interpret. It is very difficult to do it in the kids, but in adults it is very important. So the clinical examination, the most important thing that we are going to assess is how the recovery of the shoulder abductors and the elbow flexion is happening. That is the shoulder abduction by the supraspinatus and the deltoid, and by the function of the biceps. So first is this test, that is a towel test. We cover the face of the kid with a towel, and if the kid is able to move the towel, then that means the biceps is the shoulder abductors and the biceps is recovering. And actually this should happen in normal, if the normal recovery is happening spontaneously, that this shoulder abduction and the elbow flexion should be coming by the 3 months. If it is not coming in 3 months, that means we have to intervene surgically. So based upon the scientific publications, we can see that 90% of the upper brachial plexus cases, that is C5, C6 injury, will spontaneously recover. But many studies have shown that later shown that like 20 to 30% recover needs surgical intervention. So first important question is when to intervene surgically. And so we follow this protocol, that is the Allen Gilbert's protocol. That is the lack of anti-gravity biceps function at 3 months is an indication for surgery. That is the most important thing. The child won't be able to flex the elbow, that is to use the biceps, and that is the most important thing. And because biceps is only muscle innervated by only by C5 and C6, and it cannot be duplicated by any other muscles. So that is the most important thing. And there are other protocols, like some centers they will wait for like 8 months, some will wait like 1 year. But the problem in waiting is that once the neuromuscular end plates are gone, there is no role for nerve surgery in such kids, that we have to go for the secondary procedure. So that time period is very important. If there is no elbow flexion at 3 months, go for surgery. That is the protocol now. So till that surgical period, we advise the parents to mobilize the joint to avoid the stiffness, and we counsel the parents that, because most of the time it is very difficult to convince the parents, because the child will be having some false movements, like they will be able to do the shoulder abduction like this, they will be able to do the flexion like this by 3 months. Actually this is the false movement. This is happening through the conduction through the neuroma. Actually there will be an injury in the C5, C6, that is the S point, and the conduction is taking place through some connected fascicles, but this is the false movement that is happening. So we must be able to correct that. And during surgery, this actually there will be some degree of reduction in the movement initially, but the child will be able to recover in the correct anatomical way by about 1 year. That we have to convince the parents. So the surgery is done under GA. We do it under relax and free. Muscle relaxants are not given. So then we can stimulate the nerves and see whether it is working or not. We put a supraglottular exploration to explore the full plexus, and the strategy is like we explore the whole plexus and identify the point of injury. Mostly there will be a neuroma, a thick neuroma will be seen at the C5 C6 junction, that is Earth's point, and it won't be, the conduction won't be good also. So we excise that neuroma completely. So there will be a proximal root as well as distal segment, that is upper, the anterior division, the posterior division, the upper trunk. And we take nerve grafts from both lower limb. We take both the sural nerves as well as the saphenous nerve from the both limbs according to the need. If the sometimes only sural nerves may be needed, and this is a cable graft that you are seeing, and we put across the segments. So excise the neuroma and reconstruction, like anatomical reconstruction. That is C5 is connected to the posterior division of the upper trunk, and C6 is connected to the anterior division of the upper trunk. And along with that, we do the nerve transfers also. That is for the suprascapular nerve, we select the spinal accessory as a donor nerve. So a distal spinal accessory to the suprascapular nerve, that is called a distal nerve transfer. That is also done. So basically nerve grafting plus nerve transfer is the thing that we are doing. In C5, C6, C7 injury, that is called an extended Erb's palsy or an extended brachial injury. There will be injury to the C7 also. In such kids, the extension will be very weak. So we heavily graft, both limbs, nerve graft will be taken and graft the defect. So this is showing the results of the case. Right upper limb, upper plexus, grafting and nerve transfer was done. The kid at age of 8 years. Then showing all the movements: external rotation, abduction, and elbow flexion. Another kid. Means this is at 3 years.
One second.
The children are able to get almost near normal range of movement due to early surgery. This is a case of C5, C6, C7 injury. We grafted as well as did the nerve transfers, and this is the result at the 4 years of that kid.
Full light again.
This is the extended palsy.
Good boy.
The right upper.
Good boy. Friend again. Good boy. Good.
This is another case of extended palsy.
Turn the back like it.
The most important thing is the timing of surgery. All these kids they underwent surgery like about 3 months or 4 months. That is the most important thing. And for late cases, we do only nerve transfer, distal nerve transfers, like Oberlin 1, that is the ulnar fascicle to the musculocutaneous branch of the biceps, and the distal spinal axis to suprascapular, and the triceps branch to the axillary nerve. These three nerve transfers are done for late cases. This is a dissection of the nerve. This is showing the nerves. That is the ulnar fascicle. The ulnar fascicle going to the FCU is taken, and it is transferred to the musculocutaneous branch of the biceps for the elbow flexion, and the triceps branch is taken and transferred to the axillary nerve and the spinal accessory to the suprascapular. This is the result. This kid at 9 months we did the surgery, nerve transfer. She got almost all normal action. Then now we go through the late cases. We do Botox, and sometimes after surgery also there will be this co-contraction that is happening, so that we give Botox later. So late presentation, we go for the MRC release and the muscle transfer. You can see in this video that child there is no external rotation, and after surgery, after the release, you can see the full external rotation that is possible, and along with that along with that we do the LD muscle transfer to the infraspinatus and the teres major to the supraspinatus, so that the range of abduction and external rotation can be improved. Then just a few words about the adult brachial plexus injury. Basically, in the difference between adult and pediatric is that in adults, for the upper plexus I am speaking, they require only nerve transfers, not the nerve grafting, because there is no use of giving a nerve graft in that injured area. Better to go for a 4-nerve transfer. In pediatric it is 3-nerve transfer, here it is 4-nerve transfer. That 4-nerve means distal spinal accessory to the suprascapular, then the oberlin 1 and 2, that means the FCO, this ulnar nerve fascicle to the biceps, and the median nerve fascicle to the brachialis branch, and the triceps branch to the axillary nerve. These are the 4 nerve that we are getting. The result, you can see the result here. This girl with C566, there is no elbow flexion and abduction. After surgery, you can see how it is improving.
Vinu, time is over.
Yes. One more video. This is a result that we are getting by the nerve transfers in the adults. And extended palsy also, we do the same. This is a case of C5, C6, C7 injury. For external palsy, sometimes nerve grafting also is needed to get a good result. Thank you. This is our team at Susrata Institute at Elite Mission Hospital, Thrissur. Thank you.
Thank you, Dr. Vinu, for your excellent presentation and informative talk.